Okay, welcome, dear guests, to this ERKNet webinar. Today's webinar will be presented by Professor Jürgen Floege. Professor Floege is Director of the Division of Nephrology and Immunology at the University of Aachen. He has had many functions with it, ISN, ERA EDTA, and for this talk, most important, he has been the co-chair of the working group which discussed and wrote the guidelines. And today Jürgen will provide you with an update on the KDIGO guidelines on immune glomerulopathies. Jürgen, the floor is yours.
Thank you, and welcome everybody. So this, as Jacques said, will be on the KDIGO management guidelines on glomerular diseases. It's a totally outdated guideline, which, as you can see on this slide, it all started with a so-called controversies conference in 2018. And that's an instrument of KDIGO where they gather like 100 people, so lots of stakeholders and experts and pharmaceutical industry to really look into the question, what of the guidelines needs to be revised. Now, these are the recommendations of the 2012 guidelines, and you can easily see every green box indicates, no, this is not okay. It actually says, yes, this needs a revision. And you can easily see that there was a formidable task here in revising literally everything. So all you young people listening, if I can give you a good advice, if they ask you to revise this guideline and to chair it, say no, don't do it to you. It's a hell of a lot of work. It's definitely the largest guideline that KDIGO is producing because it covers so many diseases. Now, KDIGO is using the GRADE approach. GRADE has two qualities in a way. First, it has two levels. Level 1, we recommend, and this can mean that most people in your situation would want this course, but a small proportion may not. The much weaker one is we suggest. The majority would want this, but many would not. And then this is graded depending on how good the evidence for this is. High, we are confident that the true effect is very close to what we say. And D, the estimate is pretty uncertain, often will be far from the truth. So the worst of a recommendation you can have is 2D, which is just above expert opinion. And KDIGO is introducing something new. It's called practice points. Now, when KDIGO started, all they wanted to do is true guidelines based on lots of randomized controlled trials and solid evidence. Now, nephrology is a problem because nephrology is the internal medicine discipline with the lowest number of randomized controlled trials. So where my friend in cardiology is pulling out 10 randomized controlled trials to inform us, we usually have opinion and no trial because these patients are typically excluded or not studied or whatever. So we feel that it's important to give some guidance and to at least give you an expert opinion that you wouldn't call a recommendation or a suggestion, but it's better to give an opinion of a group of experts than suggesting that everybody really does what he or she wants to do. So these are practice points, and you can see these can be pretty trivial. Repeat biopsy should be performed if the information will potentially alter the therapeutic plan. But there are also some pretty controversial practice points. For example, that in the setting of nephrotic syndrome and phospholipase 2 antibodies, you no longer need a kidney biopsy. This was a pretty controversial practice point. And the next edition to come will be the guidelines going to Magic App. Magic App, as you can clearly see from this beautiful language here, is Norwegian. And it was developed in Norway, but it's now caught on way beyond Norway, and many guidelines are using this. And we hope that Magic App will contain the KDIGO guidelines later this year or maybe next year. And this, of course, would allow us to update the guidelines continuously. For example, we already know that by the time that the guidelines will be published, the lupus guidelines will be partially outdated because new trials were just coming on when we finalized the guidelines. So this will be important to allow a continuous process, and in particular for this guideline. The first guideline was published in 2012. It was based on the knowledge up to 2010, and it's now taken 11 years to update this. That, of course, is something we wouldn't like to see again. Now, all of this, what you hear today, will be published in the October issue of Kidney International. That's where you find the executive summary, which is a pretty long one already. And the Kidney International supplement will contain a several hundred-page long full guideline. So you can estimate the amount of work that went into this. And this is what will be in the guideline. We have a chapter on general principle, then we go by the most common GN, IgA, membranous nephrotic syndrome in children, minimal change in adults, FSGS in adults, infection related. And here you have something new. We changed the title. In the past, it was MPGN. Now we call it immunoglobulin and complement-mediated glomerular diseases with an MPGN pattern of injury. We realize this is a long title, but there no longer is a disease called MPGN. And then it's ANCA vasculitis, lupus nephritis, and anti-GBM glomerulonephritis. So some rare diseases, super rare, like immunotactoid or fibrillary, they're not in here. There are diseases which even we couldn't cover, and you have to realize this. So for the topic and for the sake of time today, I will limit myself to 6 conditions, which are the most frequent ones: IgA, membranous nephrotic syndromes or minimal change FSGS, ANCA, and lupus. So let's start with IgA nephropathy. The first practice point will say, and we all know this, it's important to assess the prognosis because this should inform your treatment. And you should do this using the International IgA Risk Prediction Tool in IgA nephropathy, which was developed by this large group. And it was developed based on 4,000 patients worldwide. And you can freely see it on this website. Very important. It only works at the time of the biopsy, and it will give you the prognosis up to 6.5 years. This is how long it was validated, which of course for IgA nephropathy is somewhat short. And very importantly, you shouldn't use it to determine treatment. It's important to tell the patient, look, your chances of reaching end-stage kidney disease or losing 50% of your kidney function are 17% for the next 6 years. Full stop. Nothing else. You shouldn't use it to determine, should I give, let's say, corticosteroids. And we also make the point that there are no validated prognostic serum markers or urine markers in IgA. Next practice point, the primary focus should be optimized supportive care. You should look at cardiovascular risk, and you should give lifestyle advice to these patients. Now that's particularly important. A lot of patients see me for second opinions. And in particular, oh, should I get corticosteroids? And in walks somebody with a body mass index of 35. And you have to ask yourself, what is the likelihood that I cure obesity-related hyperfiltration with a course of corticosteroids? It doesn't make sense. So lifestyle advice, usually meaning you have to lose weight, and smoking cessation, tenfold higher risk of reaching dialysis if you smoke as an IgA patient. That is an important integral part of the care of these patients. And it's clearly way beyond just giving an ACE inhibitor and that's it, which is unfortunately what a lot of studies require. Have to be on a stable, maximally tolerated ACE inhibitor, full stop. There's much more you can do to these patients. And in fact, what I'm showing here is true for literally all chronic glomerular conditions. Here comes the first recommendation, 1B. So we're pretty confident. If you have proteinuria above 0.5 grams per day and you have IgA nephropathy, irrespective of hypertension, give a RAS blocker. Now, this irrespective of hypertension may sound trivial to you, but it's very important for countries like Korea and Japan, where you cannot prescribe a RAS blocker unless you have hypertension. And only if this doesn't work and your patient is still high risk, do we suggest low level of evidence, 2B, many would not do this, that you could consider a 6-month course of corticosteroids, but we have added that the important risk of treatment emergent toxicity must be discussed with the patient, in particular if GFR is low. Side effects, adverse events really increase if your GFR is. And you should use extreme caution or completely avoid corticosteroids if the GFR is below 30, and this is not rapidly progressive GN. If you have a diabetic in front of you, if you have an obese person in front of you, and of course, this is all self-explanatory. Now, this is very much supported by the long-term outcome of our Stop IgA trial. Stop IgA, we had randomized 160 patients to either only supportive care or supportive care plus immunosuppression. The original trial phase was 3 years, but we've recently obtained evidence up to 10 years. And using a hard endpoint of death, dialysis, and 40% GFR loss, you can see that immunosuppression didn't really affect the course at all in our patients. And this also shows, and that has been a criticism initially of our trial, that we certainly studied high-risk patients. I mean, look at this, 70% of our patients reach this hard endpoint, which very much emphasizes that we need better and safer therapies than high-dose corticosteroids. Unfortunately, a lot of trials are going on in IgA. So we are living in good ages now. Let's switch topics. Membranous. Practice point 3.2.1, use clinical and laboratory criteria to assess risk. Because again, risk determination should affect your course of action. And we have come up with 4 categories. And we, meaning Jacques Wetzels, who has been an integral part of the membranous group, and Pierre Ronco and Vivek Jha, they really were driving this membranous part. There's a low risk category where patients are non-nephrotic. Moderate risk, nephrotic proteinuria, and not really changing to a major degree after 6 months. Low-level antibodies and mild low molecular weight protein. High risk, your GFR is already decreased, you're nephrotic, you have high levels of antibodies, or you have high-level low molecular weight proteinuria, non-selective proteinuria. Very high risk, life-threatening nephrotic syndrome, rapid loss of kidney function, or very high low and persistent low molecular weight protein. Here comes recommendation number 1B. We're pretty confident. If you have risk factors for progression, we recommend using rituximab or cyclophosphamide and steroids. This would be similar to what you know as the Ponticelli regimen, or a tacrolimus-based therapy for at least 6 months, with a choice of treatment depending on risk estimate. Here's what you should do. If your patient is low risk, wait and see. Maybe it disappears. There's spontaneous remission, not unusual in membranous. Moderate risk, you can allow yourself to wait and see, but just as good maybe rituximab or calcineurin inhibitor. High risk, the choice is yours. I personally don't really like CNI and rituximab. I would certainly aim for this one, for rituximab. If there's very high risk, and this is important to stress, the only treatment regimen we know to prevent dialysis, so the ultimate endpoint, is cyclophosphamide, meaning cyclophosphamide for combined with corticosteroids in an alternating monthly manner, the Ponticelli regimen for 6 months. This was largely based and influenced by Mentor. Mentor is the North American trial comparing rituximab or cyclosporin in the treatment of membranous nephropathy. And for rituximab, they gave 1 gram on days 1 and day 14. Partial or full remission was their primary endpoint at 24 months. Rituximab maintained remission in more than 50% of the patients. Cyclosporin did so in 20%. But this is a comparison of apples and oranges because treatment ended at 12 months. Now, when you stop treatment with rituximab, of course, treatment still continues because you're still CD90 cell depleted. Whereas rituximab will stop 2 days later, and not surprisingly, this is when the curves really diverge and many people relapsed. Practice point, and this is new, longitudinal monitoring of phospholipase A2 receptor antibody levels at 3 or 6 months can guide your treatment and allow you to adjust your therapy. For example, if after 3 months the antibodies are absent, you could withdraw cyclophosphamide early. You could stop your rituximab therapy and then see what happens at 6 months. And this will really allow you to avoid unnecessary therapy. Whereas in the other case, if the antibody increases, you may need extra doses or longer treatment. So antibodies really are an early sign, much earlier than proteinuria, to guide your treatment. Minimal change in FSGS. Since many of you are pediatricians, relatively little will change in the pediatric recommendation. So we have high-level recommendations, oral glucocorticoids for 8 weeks or 12 weeks if there's nephrotic syndrome, a first episode. If you have children with frequently relapsing or steroid-dependent nephrotic syndrome who are on alternate day steroids or off, we recommend that glucocorticoids are given in episodes of infection for 5 to 7 days to reduce risk of relapse. And the last recommendation, if you have frequently relapsing nephrotic syndrome or you have adverse effects from the steroids, or you are steroid dependent, then you should go to glucocorticoid sparing agents listed here at the bottom. This could be cyclophosphamide, levamisole, which has mostly been tested in India and is pretty effective. They're not so effective in Dutch children. MMF, rituximab, or calcineurin. So we really, in a way, leave it up to you which one to. Next recommendation, in adults with minimal change, we recommend sorry, this is a strong recommendation. We recommend high-dose oral corticosteroids if there are no contraindications. If there are contraindications, pick either one of these, this list. And the next recommendation is we should suggest either one of this list, cyclophosphamide, rituximab, CNIs, or MMF, if there's frequently relapsing or even corticosteroid-dependent minimal change. Now, this may change. Here's a British recent trial by the group in London, Nicholas Metchell Thomas, a British multi-center trial where they compared prednisolone and tacrolimus in adults with minimal change. And the primary endpoint was complete remission at week 8. You can see that this is not significantly different. And in fact, as you go longer to 26 weeks, they're almost identical in efficacy. Tapering was then done after achieving remission. And here's the bad news. When you taper tacrolimus or prednisolone, people will relapse. And it's only some 25% after 78 weeks, which really stay in remission. But clearly stressing that, and I believe the guideline will change here in the future, clearly stressing that tacrolimus is similarly effective, more effective than prednisolone. Now, I must confess, if it were me, I would probably prefer tacrolimus because I would probably be more afraid of the prednisolone side effects. But that's personal opinion. Let's see how the guidelines change. The adverse event rate, by the way, was comparable between the two groups. Now, going back to children, steroid-resistant nephrotic syndrome, we recommend cyclosporin or tacrolimus as initial second-line therapy, 1C. And then we give lots of guidance going from the indication for kidney biopsy to genetic testing, which is really the domain of pediatric cases, whereas in adults, often you will not find anything unless there's a syndrome or family history. And we give guidance about vitamin D and calcium and gastroprotection. FSGS in adults, this is the algorithm. If you have an FSGS lesion, the key question is my patient nephrotic? If there's nephrotic syndrome, it's likely primary FSGS, and this likely requires immunosuppression, and this would usually be 1D, high-dose corticosteroids. There's no nephrotic syndrome, but nephrotic proteinuria, or even non-nephrotic proteinuria, it could be secondary FSGS. For example, related to obesity, related to other conditions. Consider genetic screening where appropriate. That is, if there's a family history, if there's evidence of a syndrome, do not start immunosuppression. Give them supportive therapy, RAS blockade, weight loss, whatever. And only if there's worsening proteinuria or even nephrotic syndrome, then consider immunosuppression. Next topic, ANCA vasculitis. So this would be the usual tree in ANCA vasculitis. You make the diagnosis, you assess disease extent, you induce remission with either a cyclophosphamide-based or rituximab-based regimen. Ideally, you control disease on drug, and then you go to a maintenance phase, and sometime, and we don't really give good guidance because there isn't, sometime you taper treatment or stop the rituximab. So the first recommendation is that we recommend corticosteroids in combination with cyclophosphamide or rituximab as initial treatment, 1B, in new onset ANCA-associated vasculitis. For maintenance, we recommend rituximab or azathioprine and low-dose corticosteroids. I would certainly prefer rituximab because I'm burned with too many patients developing skin cancer, some even dying from skin cancer, which doesn't seem to be a problem with the rituximab. So I certainly prefer maintenance with every half year giving 500 milligrams. So that's fairly low dose immunosuppression. I haven't seen a case of hypogammaglobulinemia, but certainly this problem can exist. But to me, it certainly seems that this has fewer side effects in the very long run compared to azacitidine. What about plasmapheresis? We now have Pexivas out there, 704 patients, 18% with pulmonary hemorrhage. They were pretty sick. 20% were already on dialysis when the trial started. And it was a 2-intervention trial. It tested half the steroid dose compared to full dose and plasma exchange versus no plasma exchange. Now, plasma exchange didn't really affect the course of the disease in these patients, and the outcome was no better in terms of death or dialysis. Steroid reduction also didn't affect the course of the disease, but that's a good thing because it seems you can get away with much lower corticosteroid doses. And that has a consequence. Look at this. Serious infections in the first year, 30% lower with the reduced dose glucocorticoid regimen. No difference between the two arms in the plasmapheresis or no plasmapheresis comparison. And if you look at the low dose corticosteroids or reduced dose corticosteroid arm, let's say in a 70-kilo person, this would be starting high, 60 milligrams, but then very rapidly going down, and already after 12 weeks, you would be at 10, as opposed to much higher doses in the older protocols. And finally, let's have a look at lupus nephritis. Recommendation 10.2.1c, so fairly confident. We recommend that all patients with lupus nephritis should be treated with hydroxychloroquine or any equivalent antimalarial unless contraindicated. And there really are not too many contraindications. It could be intolerance, and of course you have to monitor your patients for retinal deposits, but all others should get it. This is because not so much the emergence of malaria in Europe. It's mostly because hydroxychloroquine is a mild immunosuppressant and it affects toll-like receptor signaling. So it's certainly a good baseline therapy on which then to add anything else. If you find class 1 and 2, which is, in my experience, pretty unusual. I rarely see this. If there's low level of proteinuria, immunosuppression should be guided by extrarenal manifestations of the lupus. If you find this class and there's nephrotic syndrome, ask your pathologist to please do electron microscopy. This could be lupus podocytopathy. You should see flat foot processes. And this would then most likely require treatment like minimal change disease, usually implying high dose corticosteroid therapy. Most frequent patients we see are class 3 and 4. 1B recommendations. We recommend that patients with active class 3 or 4 lupus nephritis, independent of whether they have a membranous component, they should be treated initially with corticosteroids plus low-dose IV cyclophosphamide. So this would be the so-called Euro-lupus scheme with 500 milligrams given every 14 days on a fixed basis. Or you give your patient mycophenolic acid, a 1B recommendation. After completing the initial therapy, you should be placed on MMF for maintenance. Now, as I said initially, this is likely to change very quickly. We now have voclosporin enter the market. We have belimumab enter the market. And in particular in lupus, this distinction of induction therapy followed by maintenance really gets blurry. And you already, in a way, see this here when you look at MMF. MMF could be both induction therapy or maintenance. So in all likelihood, in the future, we no longer distinguish between these two, maybe with the exception of the Euro lupus scheme, which of course you would confine to inducing disease remission. But in many other conditions, treatment conditions, MMF, voclosporin, maybe belimumab, we would probably have a continuous treatment with one and the same drug. And finally, class 5 lupus nephritis. If there is low-level proteinuria, again, immunosuppression should be guided by extrarenal manifestations. If there's nephrotic syndrome with class 5 lupus, RAS blocker, and my personal experience is very good with the calcineurin inhibitor in these patients, but the choice is yours. This is not very intensely studied, and the study basis to guide you is very limited. So really, we give you a lot of choices. And of course, all of them should get hydroxychloroquine. So in a nutshell, these were key things out of a huge guideline. Look forward to the Kidney International edition in October, which is where you will find all the other recommendations and practice points. And this is simply to finish off the announcement of the next seminars. Thank you for listening to me, and happy to take any questions.
Yes, thank you very much, Jürgen. So we now have time for questions, and I have received several questions, and one question is about what do you think about the role of hematuria in the prognosis of patients with IgA nephropathy?
Well, there are several studies now saying that hematuria has prognostic power. The problem is that it's so hard to standardize the assessment of hematuria. Because if you really want to use it, you have to use the same method to quantify it. A dipstick is not sufficient. Now, I'm in the fortunate situation that my lab automatically prints out a flow cytometric assessment of the urine. So I can quantify red cells per volume of urine. But you would have to use this continuously, and then it does make sense and it has prognostic power.
Okay, and in the studies of patients with IgA nephropathy, also in treatment studies, you often see that there is a percentage of patients in these studies who do not have hematuria. So would you use hematuria as a marker or a factor to consider when deciding to treat or not to treat?
Well, it depends what you mean by treatment. I would always use supportive therapy independent of hematuria.
Sure.
If you're proteinuric, use supportive care. Now, the other question, whether to use it as a decision basis for immunosuppression, I would suggest you do not. And I'm saying that based on the experience with macrohematuria triggered by infection. If you trigger the immune system with an upper respiratory infection, or very relevant for today, for example, with a corona vaccination, you develop hematuria. And I guess nobody here would use infection-triggered hematuria or vaccination-triggered hematuria as an indication for corticosteroids. That would be counterintuitive to me. So the relevance of hematuria in guiding your treatment is a little uncertain. And I'm not aware of any study that has really based therapeutic interventions on hematuria.
Okay, and the other way around, the absence of hematuria in a patient with IgA, is that something you would consider?
Same. I would be guided by GFR and proteinuria. These are the established prognosis markers, and these should be used to guide your treatments.
Okay, thank you. Then another question is, and I think you already answered a little bit, but in all the patients with vasculitis, do you prefer cyclophosphamide or rituximab?
I personally prefer rituximab. The trials that we have today suggest that both are similarly effective and both carry similar side effects, which in a way surprised many of us because we felt that rituximab is safer. That is not true based on the trials that have compared the two treatments, but we know at least from retrospective studies, when you look 10 years later in ANCA vasculitis, that the malignancy risk is much higher in the cyclophosphamide treated patients compared to the rituximab treatment. So that would certainly make me prefer rituximab. And even more so because at least in Germany, we now have biosimilar rituximab and the price has really come down.
Okay, thanks. Then in your opinion, are there patients with vasculitis who might still benefit from plasmapheresis? Or the other way around, do you never use plasmapheresis anymore?
Yeah, we still do it. And I guess that's shared by most larger centers. We would still consider this if there's severe pulmonary hemorrhage. Because Pexivas, yes, had close to 20% of patients with pulmonary hemorrhage, but the sample size was too limited to really tell us whether it made sense or not to give plasmapheresis to these patients. So we still do it. If you have severe pulmonary hemorrhage, we would plasmapherese against fresh frozen plasma.
Okay, and patients who present with dialysis-dependent kidney failure?
I would not give them plasmapheresis. There's relatively little evidence, but that's personal opinion.
Yeah, we still do, but also that's not evidence. What about the use of steroids in lupus nephritis? Can you do without steroids if you would add a biological?
Yeah, and I guess the studies will come out, and it will be really the task of future studies to tell us now that we have belimumab, MMF, steroids, cyclophosphamide, if you have to, or voclosporin, whether there's not a possibility to completely avoid steroids. And I guess the combinations of belimumab plus or voclosporin plus, that will be a task of the future to figure this out. Just like we have steroid-free regimens to maintain transplant tolerance, I don't see why this shouldn't occur in lupus.
Okay. Another question is whether you treat patients with lupus membranous nephropathy and proteinuria between 1 and 2 grams per day with corticosteroids. I know the guidelines, they have severe proteinuria, you treat, mild proteinuria, you just do conservative treatment, and there's a big debate between, you know, the 1 and 3 gram cutoff. Yeah. So what is your personal opinion for these patients?
Well, the best you should do is evaluate the circumstances. Once again, if this is a severely obese person, I would be reluctant to use any form of corticosteroid. If this is lupus podocytopathy, again, treat them like minimal change. Consider extrarenal symptoms. And only if you have done all that, then you have to ask yourself, is proteinuria severe enough? Is it not sufficiently affected by supportive care? Should I then use corticosteroids? And I feel that an important thing that should go into this decision is whether, for example, the complement levels are low, whether there's evidence of lupus activity, because easily 1 to 3 grams of proteinuria could represent scar formation, FSGS formation due to prior lupus. And if you have chronic lesions in the biopsy, if you were to biopsy these patients, I would see very little rationale to give them steroids.
Okay. Then another even more difficult question maybe is, what is your opinion for the use of eculizumab treatment in patients with lupus nephritis and concurrent TMA in the kidney biopsy?
That's a tough one, like you already said. I have no opinion. I would first make certain that you don't have malignant hypertension superimposed on this. But if you have a patient with lupus nephritis and TMA lesions that are not mediated by malignant hypertension, I would at least consider this. And of course, you have to do this by try and error, because usually you have no time to do extensive testing for complement defects. Genetic tests for us at least still take very long time.
Yeah. Although I think you would agree that this is a question for patients with severe acute kidney injury. If it's TMA on the biopsy and it is not very severe AKI, we should first maybe exclude lupus anticoagulant and antiphospholipid syndrome.
Exclude antiphospholipids.
Yeah.
Yeah,
okay.
That's for sure. Yeah, thanks.
Yeah. Then when would you consider using rituximab in a patient with steroid-dependent nephrotic syndrome? Would you do it after the steroids, or would you do it after first using CNI or MMF?
Well, the problem is, I don't know how this is handled in other European countries. The problem is that my health insurers, the payers, would really go after me if after steroids I immediately go to rituximab. They would argue this is off-label. You haven't tested all available standard approaches. So the usual thing that we do is, if somebody is steroid resistant, we give a course of CNIs, and only if that fails, then I would be tempted to go for rituximab. Or if there are contraindications for cyclophosphamide for CNIs. But it's a dilemma because it's still off-label, and I'm afraid it will stay off-label.
Yeah. Then the question on IgA nephropathy, would you use hydroxychloroquine, and would you immediately start SGLT2 inhibitors?
The hot questions. Hydroxychloroquine works in Beijing. It has not been tested outside of Beijing. But from a pragmatic point of view, I would say it's a very safe drug. It's very rare to have retinal deposits. So I see little reason to avoid it. Or the other way around, why not try it for 6 months? In the best of all cases, your proteinuria decreases markedly. It can go down 50% or more. Then it makes sense. If it doesn't work, stop it. SGLT2 inhibitors, remember we have one study so far, that's DAPA-CKD. In DAPA-CKD, yes, there were many patients with IgA, but if you want to send me an email, and I will be happy to send you the editorial that John Barrett and I wrote accompanying the DAPA-CKD IgA cohort. We are a little concerned that in that study, the control group, the placebo group, did really, really badly. And the prognosis was unusually bad, even when you use the risk assessment tool that I introduced earlier. So we have some concern that supportive measures were not used to the full extent. This doesn't take away from the fact that SGLT2 inhibitors are probably a good therapy. It probably implies that the risk reduction was not 75% or more as suggested by DAPA-CKD. Maybe lower. But like with hydroxychloroquine, you can easily argue that it's a very safe drug. The risk of genital mycosis is low because you have no diabetes. And the risk of ketoacidosis is extremely low, even though it's not zero. But overall, it's a very safe drug. And the only thing that is still a drawback, that it's still off-label. But I understand that CKD just received a license for chronic kidney disease in the US. And I believe it's only a matter of weeks or months until EMA will grant the same license to dapagliflozin in Europe.
Okay, then to continue with the IgA, there's one question about the benefits of fish oil, which is a very old discussion.
Yeah. Well, the only benefit I can see is that you scare your partner away, and the guidelines will no longer recommend fish oil. In the past, it was maybe use it. We will no longer recommend it. Plus, you have to see that some so-called natural fish oil preparations are pretty rich in cholesterol. And that, of course, wouldn't make sense.
Okay. Then a question about the treatment of ANCA-negative vasculitis.
No idea. The guidelines will say nothing about this. I think we would all treat this vasculitis like ANCA vasculitis. For example, if you have rapidly progressive glomerulonephritis in the course of IgA nephropathy, it's a very rare situation, but it does exist. We would suggest you treat it like ANCA vasculitis with low level of evidence, more opinion-based, but we have no better experience, of course.
Yeah, thanks. So one question is about what do you think about the role of complement blockers in glomerular diseases in the next 5 to 10 years, probably?
Very exciting. This is probably the most exciting area that's currently being studied. And IgA will be on the forefront. And the beauty from an academic point of view is that there are companies going against all the different pathways. There's a company going for C2, there's a company going for mannose binding lectin pathway, there's a company going for the alternative pathway, factor B, there's a company going for C3, there are companies going for C5. So within the next 5 years, we will know which of these pathways will make the race and where is the best target and the safest target, of course, in terms of complement inhibition. And it's quickly spreading to other diseases. For example, in membranous, we now have evidence that the mannose binding lectin pathway is important. That's a fairly new development because we had never understood, well, how can you have IgG4 antibodies, which are deposited in membranous, which traditionally have been believed to not activate complement. We now know that they go via the MBL pathway. So that, of course, is a logical way to go for a MASP2 antibody, which blocks the MBL pathway. And the same would be true, of course, for lots of MPGN diseases. And you have seen it in ANCA vasculitis, there's trials going on in lupus. So this is a hot area.
Yes, I agree. Then the last question, what is your therapeutic approach to patients with MPGN type 1, if it exists, proteinuria and GFR below 60, and a negative workup for secondary causes?
That is a very unusual group of patients. The majority of what we used to call MPGN type 1, and I'm stressing this because we should give up this term. We should talk about infection-related glomerulonephritis with an MPGN pattern. we should talk about monoclonal gammopathy related GN with an MPGN pattern. And I agree with you. I personally have 3 patients under my care with so-called idiopathic MPGN. I have good experience with MMF, plus minus a little bit of steroid, but the evidence base for these rare patients is very weak. In addition, you have to see that in the past, MPGN was all mixed up in one bag called MPGN. And again, I'm stressing that like FSGS, MPGN is a histological pattern. And it conceptually, it makes much more sense to go after the monoclonal gammopathy, to go after the infection, or in the very few which you don't know, to then use immunosuppression. But this separation has never been made in the past. So it's very difficult to extrapolate from historical studies to today's knowledge.
Yeah, I agree, and I think that's the important in this new guideline. This MPGN chapter has been rewritten, and the diagnosis of MPGN as a disease has changed. Like FSGS is not a single disease. Okay, well, thank you very much, Jürgen, for this very nice webinar. I thank all the audience. I wish all of you a good summer holidays, and the ERKNet webinars will continue after the holidays, and the first one will be September 7 on renal hypophosphatemia. I wish you all a good day, and I say hello. Bye-bye, Jürgen. Bye-bye, Stephanie.
Thank you, Jacques. Thank you all.
Okay. Bye-bye.